Good morning, good afternoon, or good evening, based on where you are, and welcome to today's webinar. My name is Laura Galanos. I am the Executive Manager of the World Stroke Academy, which is the educational platform of the World Stroke Organization. Now, it is with great pleasure that we are hosting this educational activity today. We have over 1,300 of you who have registered for a webinar on cerebral small vessel disease with exceptional speakers who will be sharing their expertise on the topic. Now, as per usual, before introducing today's moderator and our speakers, we'll have a quick look at our housekeeping rules. We welcome any questions you might have throughout the webinar, but we kindly ask you to use the Q&A box for those in your Zoom control panel. You can also, of course, use the chat box to say hi, let us know where you're joining us from, or leave any comments. You can also participate in our polls, which we have prepared throughout the webinar, and they will be popping up on your screen. So we invite you to vote during those ones. And then a reminder that the webinar is indeed recorded, and the recording link will be sent out to you via email shortly after the webinar, but it will be also uploaded on the World Stroke Academy YouTube channel and site. Lastly, we kindly invite you to fill in the evaluation survey at the end, which is a great way for us to know your feedback, what other topics you're interested in. So please do fill it in. It will automatically pop up on your screens when the webinar ends. Now, without further ado, let me introduce today's chair and moderator, Professor Bo Norrving, professor in neurology at Lund University, Sweden, and Dr. Anna Bersano, director and neurologist at the Fondazione IRCCS, Istituto Neurologico Carlo Besta in Milan, Italy. Thank you for being with us today, and the floor is all yours.
Well, thank you very much. I'm very pleased to share this session together with Anna Bersano. So World Stroke Academy, this is one of the flagship activities of the World Stroke Organization. This is provided to you free. There is no honoraria for the speakers. This is for your purposes. This is for your education. What we want back from you is to fill in the evaluation form, but otherwise you can just enjoy. So the topic of today is cerebral small vessel disease. And some 50 years ago, we thought we knew everything about this. It was a small vascular occlusion. It was lacunar stroke presentation, and then it's been a remarkable development and still is ongoing. It still remains a hot topic in cerebrovascular disease. So much we don't know yet, so much that needs to be studied. So we will have an update on several aspects of this today by three excellent speakers. We will have the question and answers by the end, so you can prepare your questions in the chat box. And I'm happy now to introduce the first speaker. Is Chen from Singapore. Chris is at the Departments of Pharmacology and Medicine, National University of Singapore, and the National Medical Research Council. Chris is extremely well known for his contribution to small vessel disease, cognitive impairment, dementia. So Chris, over to you. The floor is yours.
Thank you so much. Bo, I think that we're going to have our first question now. Laura, you're supposed to tell them what to do.
So the question is, what is the most common pathological change in cerebral small vessel disease? And you have three answers: vasculitis, amyloid angiopathy, and atherosclerosis. You can put your answers right now into the poll. We will wait a few more seconds, and then we will ask you again at the end of Chris's presentation. So here are the first results.
Excellent. So I don't need to give this lecture. Okay. Well, thank you very much to organizers for putting this together. I think, as Bo says, this is a really, really fascinating and important topic, and I'm very honored to be able to go and sort of update you on the pathophysiology, epidemiology, and risk factors for cerebral small vessel disease. And it's issue that's very dear to my heart because we have a lot of this in Singapore. Okay, here are my disclosures. I'm funded by the National Medical Research Council of Singapore, and I serve on advisory boards for several companies, but none of this is relevant to this talk. So, as has been well reviewed by Professor Wardlaw in the publication Lancet Neurology 2019, cerebral small vessel disease is very common, especially during aging, and it can present in a multitude of ways, not just as stroke, but as Bo said, as cognitive impairment and dementia, as mobility and gait dysfunction, and also as neurobehavioral or mood disorders. So it's a very pleiotropic condition. And it frequently coexists with neurodegenerative disease, especially Alzheimer's disease. And presence of cerebrovascular small vessel disease can exacerbate cognitive and other symptoms and affect activities of daily living. It's often a very silent disease, but it has huge consequences. Now, the term cerebral small vessel disease refers to really all the pathological processes that affect small vessels of the brain. And these include not just the small arteries and arterioles, but also capillaries and veins. But more often than not, cerebral small vessel disease is used only to refer to the arterial vessels. And as all of us know from our neuroanatomy, these arterial vessels have two origins. So they can either come from the superficial subarachnoid circulation as the terminal vessels of these medium-sized arteries, which originate, of course, from larger arteries, or they can be arterial perforators from large vessels at the base of the brain. Now, these two systems converge towards each other, and they merge in the deepest parts of the subcortical white matter, which, as you know, is a watershed area. So this means, of course, that much of the pathology of or consequences of small vessel disease is in the subcortical area, although, of course, there may be some cortical effects. But this also means that because it's in the watershed area, diseases of the large vessels may also mimic small vessel disease. Neuropathologically, Leonardo Pantoni has proposed a simple etopathogenic classification of cerebral small vessel disease. And types 1 and 2, which are arteriolosclerosis and the sporadic and hereditary forms of cerebral amyloid angiopathy, are the most common. But of course, arteriosclerosis, as many of you have pointed out, is the most common pathology. But more rarely, there are also inherited or genetic small vessel diseases such as CADASIL, CARASIL, MELAS, Fabry's disease, as well as inflammatory and immunologically mediated small vessel disease, which are very rare, but are characterized by vasculitis, usually part of a systemic disease, such as Wegener's granulomatosis, Church-Strauss syndrome, etc. There's also venous collagenosis, which is a pathological thickening of the vessels of veins and venules, which are closely located closely to the lateral ventricles, and may be also a major cause of white matter lesions. And there are rarer forms of small vessel disease, such as, for example, post-radiation therapy, angiopathy, etc. But I think it's important to emphasize that the most frequent will be arteriosclerosis and angiopathy. This is what you may find when looking under the microscope for cases of small vessel disease. Arteriosclerosis is mainly characterized, as you see at top left, by loss of small muscle cells, deposits of fibrohyaline material, and leading to narrowing the lumen, thickening of the vessel wall, and eventually occlusion. This is a very common pathology which is found not just in the brain, but also systemically, kidneys, in the retina, and is associated with aging, diabetes, and in particular, of course, hypertension. There are other pathological features such as microatheromas and microaneurysms, but the main feature really is the thickening of the walls of the small vessels. The consequences are, as illustrated by this nice chart, is that if you have small vessel disease, two possible things can happen. One is that because you lose the smooth muscle cells, you have lumen restriction, it reduces blood flow, leads to chronic diffuse subclinical ischemia or acute localized ischemia. And this can either lead to incomplete infarcts or focal infarcts, which can show up on imaging. Or because of vessel wall damage, it can lead to microaneurysms. And this leads to rupture of the vessels, which either lead to small microscopic bleeds, which again can be seen on the MRI, or macroscopic bleeds. And of course, because of these pathologies, you also have damage to the blood-brain barrier, which is very important because it also leads to ischemia. You have inflammation, and you may have apoptosis of other cells, including the very vital oligodendrocytes. Now, because we cannot really visualize small vessels in vivo, I think that some people are trying to measure these using 7T MRI, for example, but still it's really difficult to do so. The lesions which are in the parenchyma that are caused by these small vessel changes have really been adopted as the markers for cerebral small vessel disease. And the next speaker is going to be talking about these MRI types, these lesions which are characterized by MRI, such as recent small cortical, subcortical infarcts, lacunes, white matter hyperintensities, etc. And these are very well summarized in the STRIVE-1 and STRIVE-2 papers for those of you who are interested in finding out more. Even though we can use these markers to examine the prevalence and risk factors of cerebral small vessel disease, there really are a number of challenges which have made things less clear in the field. Firstly, as I've said before, the clinical expression of cerebral small vessel disease is very variable. So the clinical diagnosis is difficult. As you know, in epidemiology, the prevalence of whatever you want to look for very much depends on your target population. And because this leads to different risk factor profiles. So the prevalence of small vessel disease will be different in the community, stroke cohorts, and in dementia cohorts. It very much depends on who you're looking at. And even though there are standardized definitions for the MRI features of small vessel disease, these criteria are not always applied in studies, and they may vary due to time. Moreover, because there's no single neuroimaging biomarker for cerebral small vessel disease, studies will vary a lot in what they use. So maybe there's a real need in the future for summary statistics or for MRI markers which capture the downstream effects of these lesions. There are also a lot of variations in the neuroimaging protocols and assessment methods. And the prevalence of small vessel disease may differ, and we'll talk about that later, depending on ethnicity, geography, culture, vascular risk factors, genetics, and of course the public health policies of the region. I think that we often, at least I often get the feeling when I'm looking at the different lesions that we see on MRI, that we all think we're describing the same thing, but we might not be, as illustrated by this cartoon. Nevertheless, a large number of community-based studies have been performed using MRI as the definition of small vessel disease. And they have been able to go and give an estimate of, for example, white matter hyperintensity burden. And this ranges from small numbers to very high numbers, as you can see. And the risk factors include age, vascular risk factors, other measures of cerebral vascular disease, gender, smoking, etc. And there also are studies looking at white matter progression, and you can see that there is a considerable percentage of cases who go on to develop more white matter disease. And again, the risk factors include vascular risk factors and age, as well as your baseline level of white matter hyperintensities. Similarly, many studies have looked at the prevalence and risk factors for microbleeds. And again, this depends on a variety of features, including your MRI field strength, and the prevalence rate goes up from about 3% to over 15%. And the risk factors, again, are vascular risk factors and age, particularly driven by hypertension. In terms of lacunes, the frequency of lacunes ranges from 8 to 31%. And this is very much driven by the age of the study population, as well as the ability of the imaging methods to resolve very small infarcts, smaller infarcts. And whilst the risk factors have varied between the studies, again, hypertension, age, to a lesser degree, smoking seem to be most replicated. And there are several other risk factors which are less robust, lacunes, including renal impairment, diabetes, cholesterol, homocysteine, and ethnicity. Nevertheless, these markers of small vessel disease appear to be clinically very important. In an excellent review by Stephanie Debet and Hugh Marcus, who identified 46 longitudinal studies evaluating associations of white matter hyperintensities and other clinical outcomes, they have found that white matter hyperintensities were associated with increased risk of stroke, dementia, and death. And here's the forest plot for risk of stroke. You can see that it's really quite homogeneous. There's usually a high risk, and in particular in high-risk populations. On the other hand, when you look at dementia, the risk of dementia is highest in the general population, but lower in those with a high risk of dementia, presumably because there are other pathologies kicking in. And similarly for death, there's a high risk, a strong risk in the general population, and a lower risk in the higher risk population, again, probably because there are other causes. I alluded to the fact that there may be differences in the prevalence of small vessel disease between different ethnicities. And this is driven by the clinical finding that lacunar strokes, for example, are much more common in non-Caucasian populations. But there are very few population-based study data available on white matter hyperintensity burden. And in particular, there are very few studies which are conducted by the same groups. So one of the initial studies was undertaken by Vincent Mock, who compared a Chinese study from Shanghai with a study from Tasmania, which was all actually on white Australians. There was only a single rater for the white matter hyperintensities, lacunes, and micro. And what they found was that confluent white matter hyperintensities was more prevalent in the Chinese population, 36% versus 28% in the white population. And in a multivariable logistic regression, including age and all the other risk factors, Chinese ethnicity was associated, remained significantly associated with confluent white matter disease. So we decided to undertake, to pull together 3 population studies across Asia to see whether this high rate of cerebrovascular small vessel disease was actually the case. And we put together a study from Singapore, from Hong Kong, as well as from Korea. And what we found was that Asians indeed do have a high prevalence of small vessel disease, at least in community-based studies. Up to 37% had confluent white matter hyperintensities, 25% had lacunes, and about 27% had microbleeds. Major risk factors were age and hypertension, and this increasing severity was associated with worsening cognitive performance. And we speculated that the higher burden of small vessel disease in Asians might be due to an increased burden of vascular risk factors, environmental factors, genetic factors, etc. Our colleagues from Hong Kong have taken this further in doing a much larger meta-analysis of small vessel disease in low and middle income countries. This very busy slide just illustrates to you the highly heterogeneous results that they found. Suffice to say that the median prevalence of cerebral small vessel disease markers was highest in stroke and dementia cohorts, but was also pretty high in the community. And really, I think that one of the things that we really need to do in the future is to have more population-based studies to assess small vessel disease in low and middle income countries, especially from Africa, Central Europe, Eastern Europe, and Central Asia. And if we're going to do such studies, we should at least use 3T MRI, harmonize methods for reporting the neuroimaging markers and assessment of other small vessel disease markers, in addition to the usual white matter hyperintensities, wounds, microbleeds, and perivascular spaces. And then really understanding the prevalence of small vessel disease in different global regions, as well as their clinical manifestations, can help improve our understanding and management of this disease. And I'll end by saying that one of our important challenges is identify who are the high-risk groups for progression. Not only should we use neuroimaging, but I think we should use blood biomarkers, and that we need to develop effective treatments, better understanding of the pathophysiology. And these include not just ischemia, but also hypoperfusion, blood-brain barrier breakdown, and microstructural damage. And to perform well-designed trials, as Dr. Wardlaw will soon enlighten us on. Thank you very much for your attention, and here's the quiz again.
Thank you very much.
100% now.
Very interesting. So please fill in the response to the poll. So we will have it up for about 10 more seconds, and then we will take a look at the vote. So Laura, you can decide when we should stop it. Yeah, here we have it.
Oh, better.
Chris, this is very convincing. You did a good job. Yes. Thank you very much. So we will proceed directly with the next speaker is Simon Frandler-Höfler, who is our next speaker. Simon is from Austria, from Graz, and he did his PhD under the mentorship of François Secas. Recently come back from London at the fellowship at Queen Square with David Waring. Now back again in Graz, and very active in research in neuroimaging, in acute vascular disease, cerebral vascular disease, and intracerebral hemorrhage is also one of your topics. So you will speak to us on cerebral small vessel disease, neuroimaging, and clinical implications. So Simon, the floor is yours.
Many thanks for that very kind introduction, and also for the honor of speaking here to such a large audience, which such a highly esteemed speakers. So I feel very small with all these giants before and after me, but I'm very happy to talk about this important topic. I do not really want to repeat a lot of the things that have been said before, but cerebral small vessel diseases cause a massive clinical burden. They cause about 1 out of 4 of all ischemic strokes. They cause the majority of intracerebral hemorrhage, the majority of vascular dementia, and they amount to probably more than 2 million deaths and more than 50 million of disability-adjusted life years lost every year. But we know that MRI is the gold standard to assess the presence and severity of cerebral small vessel disease, at least in commonplace clinical practice. And that's why in this talk, we'll talk about recognizing acute manifestations of small vessel disease on neuroimaging, but also chronic small vessel disease findings. And we will also discuss the clinical implications of the neuroimaging findings, especially how to use the neuroimaging to differentiate causes of ischemic stroke and intracerebral hemorrhage. And as already mentioned, the STRIVE criteria give a very, very good overlook on all those things. So if there is one publication, one paper you would like to read after this webinar, I would very much recommend this one, the STRIVE-2 publication that has been, the STRIVE-2 paper that has been published in the Lancet Neurology earlier this year. You find the QR code with the direct link to the paper, and it very nicely outlines the different neuroimaging findings, the more frequent and the more recently discovered ones, with excellent definitions and very easy, good to use hands-on. So this is a very, very important piece for research, but also for clinical practice. And I will briefly show you the most important acute manifestations of cerebral small vessel disease on neuroimaging first, and I'd like to slightly try to distinguish those of atherosclerosis or deep perforated arteropathy, and we previously, as many of you will know, called this hypertensive small vessel disease, which we're not so happy to call it anymore, and also of cerebral amyloid angiopathy, because these two most frequent causes of cerebral small vessel disease, they do have quite different neuroimaging markers, but at the same time, they also overlap in some. So the most frequent acute manifestation is the recent small subcortical infarct, as seen on this DWI MRI sequence, diffusion weighted images. And the most dramatic one is intracerebral hemorrhage. You can have intracerebral hemorrhage both in deep locations, which means basal ganglia, thalamus, brainstem, and in those locations, it is very frequently caused by atherosclerosis. Obviously, there's other non-small vessel disease related causes of hemorrhage, which we're not going to talk about in this talk. But atherosclerosis very frequently causes these deep intracerebral hemorrhages. But we also have lobar intracerebral hemorrhages, and here the diagnosis is slightly more difficult because it could be both cerebral amyloid angiopathy or atherosclerosis that could cause lobar bleedings. And then slightly rarer and slightly more difficult to diagnose is convexity subarachnoid hemorrhage, which can be quite difficult to distinguish on CT. You usually have this slight hyperdensity in a single sulcus, and it might be difficult to distinguish them if you're not especially looking for it. They're a lot easier to distinguish on MRI. For example, here on this FLAIR sequence, you see the acute convexity subarachnoid hemorrhage. Recent small subcortical infarcts are defined as the neuroimaging evidence of a recent infarction in the vascular territory of a perforating arteriole with related clinical symptoms. And it should not be too much mixed up with incidental DWI positive lesions, which means you see a small DWI lesion in the same vascular territory, but without clinical symptoms. The majority of RSSIs are small vessel disease related, but it's important to note that other causes such as branch artery disease or cardioembolism are also possible and might change the both acute and long-term treatment. And what's very interesting about these recent small subcortical infarcts is that they have quite varying long-term dynamics in neuroimaging. So for example, in this study a few years ago, we've showed, but many other groups have shown this as well. So these are 3 patients that have a recent small subcortical infarct, and the first patient, it developed into a lacune. In the second patient, it developed into one patchy white matter hyperintensity, and in a third patient, throughout follow-up, it completely disappeared. And there's even, as outlined also in the STRIVE publication, there's even different manifestations of these long-term changes after recent small subcortical infarcts, which are overlaps between those 3 and also hemorrhagic types. But these are probably the most frequent or most important ones. So it's important to note that these infarcts have quite different dynamics in terms of neuroimaging. I want to briefly also talk about convexity subarachnoid hemorrhage, because I feel like they are frequently under-recognized, and they have a quite different clinical manifestation, which is important to be aware of. And these are those transient focal neurological episodes, or TFNEs, that we have been calling amyloid spells previously. And these TFNEs are sometimes misunderstood as a TIA or sometimes as a seizure, because they are short episodes of focal neurological symptoms that usually quite rapidly disappear again. And they can consist of paresthesia, paresis, or other focal neurological signs. But importantly, they're often a combination of both positive and negative symptoms, even though it could also be either one of them. So compared with a TIA, where we usually have negative symptoms such as hemiparesis, a TFNE often also have positive symptoms such as paresthesia. And what's very important in the differentiation of TFNEs against TIA, or for example, is that TFNEs usually show a spreading progression. So patients describe this migration of symptoms, for example, a tingling that starts in the fingers and then slowly within a few seconds or minutes goes up the arm and then reaches the face, and then step by step also dissolves again. And with TFNEs, we've also frequently see repeated stereotypical episodes. So these episodes can repeat similar to a focal seizure, but still different. And the most important cause of these clinical symptoms that are caused by these convexity subarachnoid hemorrhages is cerebral amyloid angiopathy, or in other words, again, cerebral small vessel disease. And it's very important to diagnose this correctly, because the management is quite different. Obviously, with the TIA, you would give antiplatelets, you would control different risk factors. But if you correctly identify convexity subarachnoid hemorrhage, obviously, there's much less indication of giving antiplatelet or anticoagulant drugs, because we know if they're CA related, there's a quite high risk of intracerebral hemorrhage in the next years, in the next actually days, weeks, months, but also years. There are many chronic manifestations of cerebral small vessel disease, and some of them have already been mentioned. For example, lacunes, as the one you're seeing here on the yellow arrow, enlarged perivascular spaces, either in the basal ganglia on the left or in the centrum semiovale on the right. Cerebral microbleeds, they can also, like the intracerebral hemorrhage, usually distinguished in deep and lobar locations, because again, as with hemorrhage, lobar microbleeds could be caused by either atherosclerosis and cerebral amyloid angiopathy, but deep cerebral microbleeds are usually caused by atherosclerosis and not by cerebral amyloid angiopathy. Then there's the white matter hyperdensities, which is probably the most frequent feature, although I should probably say white matter hyperdensities of presumed vascular origin, because there are other diseases such as demyelinating disorders that can cause relatively similarly looking white matter changes. And furthermore, there's cortical superficial siderosis, which we think is the residue of repeated convexity subarachnoid hemorrhages, and which we can very nicely distinguish on T2 gradient echo or susceptibility weighted imaging. I want to briefly talk about clinical implications. For example, in a patient with ICH, I'll show you two patients actually with an ICH. First, a 57-year-old male patient with cerebral ICH. He doesn't have any known risk factors, and the MRI otherwise of the hemorrhage is completely normal. And there's a second patient, 40 years old, a little bit younger, also male, no risk factors, lobar ICH. But on imaging, you see those quite extensive small white matter hyperdensities. You see lacunes, you see microbleeds. So the question is, how does the neuroimaging change? Why do we even do the neuroimaging aside from the primary diagnosis? In both of these patients, the routine workup did not show a clear case cause of hemorrhage in both patients. So what are we going to do next? And just want to give you the 10 seconds of thinking about how would you approach these patients? Would you do any additional investigations? for workup of the cause of this intracerebral hemorrhage? And if so, would you differentiate your workup between those two patients? This is something, obviously, there's not a lot of actual study or randomized evidence at all how to approach this, as with many clinical practice questions. But personally, I think, and some evidence shows us this quite well, if we see an intracerebral hemorrhage and there's a lot of associated small vessel disease, we can kind of assume that this most likely is the cause. But in the first patient where we see a hemorrhage and we see no small vessel disease, we really have no cause established. So in this patient, it would be probably indicated to do more intensive workup in regards of the cause of this hemorrhage. And in this case, on digital subtraction angiography, we saw a small AV malformation that wasn't visible on CTA because it was quite small and was the cause of the hemorrhage, which of course changes treatment. And in the other patient with the small vessel disease related ICH, probably we wouldn't need to do DSA angiography. We did it anyway, and we found, as expected, no changes. One other patient with ischemic stroke. So this is actually a patient I saw just last week. As 38-year-old male patient had reduced sensation of the left fingertips, toe tips, and lip, but all of this with an acute onset 1 day ago. He has no medical history, no medication, no allergies, but he had quite alarmingly high blood pressure of almost 240 millimeters mercury systolic. And when I asked him about the blood pressure, if he's kind of aware of this, he said he's never ever measured blood pressure in his life, and he doesn't know if this is something that might have been going on for a longer time. After controls, the blood pressure was similar. So we did MRI. In the MRI, you see this recent small subcortical infarct. On the FLAIR images, you see those small early white matter hyperintensities, a lacune here, more white matter hyperintensities. And you also see this enlarged perivascular spaces, which are not that extensive actually, but quite extensive actually for a 38-year-old patient. So now it's kind of the question, because obviously in any setting, we have to think, what do we focus on? What are the next examinations? What do we want to look at? And this is what I want to ask you. So which workup would you focus on this patient? Would you look for a PFO using transesophageal echo? Would you check for genetic small vessel disease? Would you check for secondary hypertension, or would you look for arterial dissection? Obviously, all of those 4 questions are not wrong. I think there's maybe slightly more right than the others. So all of these things, obviously, you might do in a patient with juvenile ischemic stroke. But I think in this overall setting, there's one option that might be more correct than the others. I'm curious about the results, and I would agree with the majority of you. So, of course, genetic cerebral small vessel disease is quite important differential diagnosis in such a patient, but the very high blood pressure potentially indicates that this is not so much a genetic disease, but probably more caused by this very important risk factor of cerebral small vessel disease. So what we did is to look for secondary hypertension, and we did actually found, I feel like we often look and we rarely find it, but in this patient we found a severe renal artery stenosis, which was probably caused by changes, and which is probably responsible for the hypertension and therefore the cerebral small vessel disease. Last example, another patient when things slightly more go wrong. So this is a 64-year-old patient, again, presenting with a mild right hemiparesis and a recent subcortical infarct. Again, quite extensive small vessel disease, lacunes, white matter hyperintensities, a few microbleeds here in the pons. He has severe hypertension, he has type 2 diabetes, but there was really suboptimal risk factor management. So the patient refused, even though he was prescribed, he refused to take any preventive medication. And unfortunately, 5 years later, we saw him again with this very extensive, deep intracerebral hemorrhage, which also led to his death, unfortunately. And this should just underline that it's very, very important to control risk factors. And obviously we can't establish causality in this case, but we're very confident that with better risk factor management, we can slow at least the disease progress and reduce the risk of such things happening. So the takeaway message is neuroimaging and especially MRI where available is critical in the assessment of cerebral small vessel disease. And neuroimaging patterns are very helpful in determining the etiology of ischemic stroke and intracerebral hemorrhage, because adequate identification of these etiologies allows us to individually tailor secondary stroke prevention, which I think is very important in patients with any manifestation of stroke. There are a few references that I've been citing throughout the talk. Best regards from Graz in Austria, and thank you for your attention.
Simon, thank you so much. Very, very interesting. So now we will proceed. We will move on to interventions, and I'm happy to present to you Joanna Wardlaw from Edinburgh, University of Edinburgh, and the UK Dementia Research Institute. You will speak about pharmacological and lifestyle intervention. And Joanna really is one of the pioneers in this field with so many original ideas that you come up to over the years. So Joanna, over to you. The floor is yours.
Thank you very much. Thank you for the opportunity to participate in this webinar. I don't have any industry disclosures. I have been involved in chairing the ESO guideline on small vessel disease. There's a poll which you can vote on, just while I continue these introductions, or maybe I can't while you vote. I have to stop there for a minute. I guess it repeats, what proportion of lacunar ischemic strokes do you think are due to atherosclerosis or cardioembolism? Obviously, this has a big implication for treatment and prevention. Interesting. Okay. Let's move on. Here we are. I won't repeat the information about pathology, which Chris has covered very nicely, just to say that the majority of small subcortical infarcts and small vessel disease are due to arteriolar sclerosis, lipohyalinosis, fibrinoid necrosis, which mostly is not a microatheroma. We've heard about the risk factors. It's important to consider other risk factors such as diet and exercise, and the vascular dysfunctions which occur in small vessel disease are now quite well documented, including reduced cerebrovascular reactivity, leakage of the blood-brain barrier, and increased vascular stiffness. These are the learning objectives. I'm going to focus on lacunar ischemic stroke and covert small vessel disease. Covert small vessel disease is the term which is used to refer to people who have not had any history of stroke or vascular cognitive impairment, but when they have a brain scan for some other reason, they're found to have evidence of small vessel disease, white matter hyperintensities, or other features. Patients who present with a stroke presentation of small vessel disease typically have a stroke with lacunar syndrome symptoms and a lacunar ischemic small subcortical infarct on brain imaging. So the next two slides summarize the overall current knowledge of management based on work that I did with colleagues as part of the European Stroke Organization guidelines. The guideline on covert small vessel disease was published in 2021, and the guideline on lacunar ischemic stroke is in review and hopefully will be published soon. It was presented a couple of weeks ago. Clinical management of covert small vessel disease. So this is to prevent the future complications developing, effective treatment of high blood pressure as per current guidelines, some evidence that lower blood pressure targets might help reduce white matter hyperintensity progression, avoid antiplatelet drugs unless there is another good indication for the treatment, such as ischemic heart disease, lipid lowering as per primary prevention, smoking cessation, other guideline, lifestyle advice, good exercise activity, diet, etc., and no evidence of any benefit from anti-dementia drugs, and diabetes should be managed as per current guidelines. For clinical management of lacunar ischemic stroke. We divided this into the acute phase and the secondary prevention phase. In the acute phase, and this is a general problem, much of the data on lacunar ischemic stroke comes from trials in which lacunar ischemic strokes were included, but they weren't necessarily subtyped very well, or the results were not presented according to the lacunar stroke subtype. So we're really digging in some deep water here and trying to separate out the fog, and it's been a quite frustrating experience. But the bottom line is there's some evidence for benefit of alteplase, assuming that the patient meets other thrombolysis treatment guidelines. There's some evidence of benefit of starting an antiplatelet drug in the acute phase, and some very secondary evidence of potential benefit of a dual antiplatelet given short term, but very limited evidence. No evidence to support acute blood pressure lowering, like for other types of stroke. Very limited evidence on any particular beneficial intervention for progressing lacunar stroke, and not much evidence for other treatments apart from avoid GTN and avoid heparin acutely. For secondary prevention, a single antiplatelet drug given long-term, and the strongest evidence is for aspirin or clopidogrel. Antihypertensive, blood pressure should be managed according to existing guidelines, with no evidence for lower targets or specific drugs beyond what's already in current guidelines. Lipid lowering, limited data, probably a good idea, a bit like for covert small vessel disease. Lifestyle interventions, really important. I think we probably neglect those. And some evidence for other treatments, work in progress, but nothing strong enough to make it into a guideline as yet. Just like to highlight a couple of bits of information about antihypertensives and antiplatelet drugs specifically. So this is about covert small vessel disease and antihypertensive medication. And of course, antihypertensive therapy is guideline for primary and secondary prevention of vascular events. So covert small vessel disease should be no different. Now, on the question of whether more intensive blood pressure lowering reduces white matter hyperintensity progression, then there is some evidence from a small number of trials that more intensive blood pressure lowering may help reduce white matter hyperintensity progression compared with usual blood pressure levels control, and no evidence for a specific drug. However, the amount by which blood pressure lowering restricts white matter hyperintensity growth is very small. We're talking about 1/10 of a teaspoon over 3 to 4 years. So antihypertensives are really important, but they're not having the sort of massive effect that you might hope they would have if this was the whole story. In lacunar ischemic stroke, there's 2 trials, quite a large amount of data, over 3,000 patients, but not reaching a conventionally significant result in terms of stroke prevention. However, you need to treat blood pressure, but no evidence really to support lower levels, but good blood pressure control is really important. No evidence of benefit long-term on cognition from either of these 2 trials. So something else we need to find to fix the problem. For antiplatelet drugs in covert small vessel disease, there is good evidence that you should not be treating patients with covert small vessel disease with antiplatelet drugs, and that comes from trials in primary prevention and other sources. Antiplatelet drugs in primary prevention are probably harmful, and there's no evidence of any benefit on cognition or white matter hyperintensity progression. In patients with lacunar ischemic stroke, there's a modest amount of data from acute trials and quite a lot of data in secondary trials. But again, this problem, the lacunar data is buried in amongst all the other information. Bottom line, for secondary prevention, and this is one of a series of meta-analyses and also network meta-analyses that we were able to do, long-term secondary prevention with aspirin or clopidogrel, if that's your preference, no evidence of superiority. Definitely not using dual antiplatelets long-term, that is hazardous. Network meta-analysis did not show any benefit for any other agent over and above single antiplatelet. So slightly frustrating, but message, use single antiplatelet. Just to summarize the evidence on lipid lowering, as I said earlier, is probably a good idea. There's not much evidence of harm. On the other hand, there's not a huge amount of evidence of benefit either on white matter hyperintensity progression or secondary stroke prevention, in part because the lacunar data is hidden in amongst other stroke subtypes in trials, but it should be implemented. Lifestyle, really, really important. It's widely and strongly recommended in all primary prevention guidelines. I think we don't give enough attention to physical activity, and I don't think we do enough to try and help patients stop smoking. And if that's the only two things you can do, that's probably going to be extremely effective. Advocating a good diet, particularly avoiding excessive salt intake, is really important. And just to hammer this message home, that while these stroke prevention and stroke treatment type approaches are extremely important, they're not dealing with the whole problem, because this is from a longitudinal study that we've been doing now, up to 230 patients scanned serially over the course of a year, and at least 25% of them get new DWI lesions appearing. Some of them, vast majority of them, are not symptomatic. They would not have caused stroke-like symptoms. And this is in spite of getting optimum secondary stroke prevention. So we're not adequately managing this condition just by implementing secondary stroke prevention. So a number of us have tried to look at other approaches, thinking about the endothelial dysfunction aspect of small vessel disease, which is becoming clearer. And this slide just lists a number of these approaches, trying to damp down inflammation, looking at a number of different endothelially active drugs in short-term studies, looking at secondary intermediary outcomes such as cerebrovascular reactivity, looking at the effect of different antihypertensive agents on cerebrovascular reactivity short-term, exercise, other drugs, and the LACI-2 trial, where we tested isosorbide mononitrate and cilostazol in a factorial design. These are both endothelial active drugs, to see if we could find any hint of any benefit long-term. This just summarizes a couple of the results from the LACI-2 trial, which was published earlier this year in JAMA Neurology. Slightly surprisingly, but actually when you think about it, maybe not that surprisingly, isosorbide mononitrate, which is a nitric oxide donor, helped to reduce cognitive impairment at 1 year. And when you put isosorbide mononitrate and cilostazol together, you get an even better effect. Dependency was reduced by cilostazol individually, and when you put the two drugs together, you got more benefit. So some evidence of benefit in terms of small vessel stroke. Isosorbide mononitrate also reduced recurrent stroke. This is a small trial. It was less than 400 patients. The results need to be replicated, but putting this body of work together suggests that attacking a more endothelial approach may be a way to go, in addition to whatever we can do with secondary conventional stroke prevention. So important messages: treat blood pressure effectively, avoid antiplatelet drugs in covert small vessel disease, use a single antiplatelet drug after lacunar ischemic stroke, with some evidence for benefit of a dual antiplatelet in the first few weeks, but not long-term. Lipid lowering, lifestyle interventions are really important. It's worth pointing out that most of the meta-analyses that underpin this work did not reach significance, so we do need to be slightly cautious, and we certainly need more trials. Conclusion: the evidence base is not great, but we have to apply what we know at the moment. It underpins that most lacunar ischemic stroke is probably not atherothrombo or cardioembolic, and we can follow general stroke guidelines, but we need to use those with caution. There are references which you can look up, additional resources, and I would just like to thank my colleagues on the ESO guidelines who made massive contributions to this work. So thank you very much.
Thank you very much, Joanna. Very informative. So now we have the chance to look again at poll number 3, and please cast your votes. We'll have it open for 10 to 15 seconds and then close it. So here we see the results. You have yes.
Results. Yes.
Right. Thank you so much. So now I give the floor over to Anna Bersano for the questions and answers. As you can see, it's been very active with a lot of questions. So Anna, over to you.
Thank you, Bo, and thank you to all for this excellent presentation. We had a very, very good webinar with a high-level presentation. So we started with the first question from the Q&A section. The first question is for Chen. What do you think is necessary to improve the case finding and the workup of cerebral small vessel disease in clinical practice, since the small vessel disease manifestation are so different and so broad, and it's often hard to differentiate from other conditions? And do you think that in this case OCT and DVOA evaluation can be useful?
I didn't catch all that question, but I wouldn't have any, I don't think there's an opportunity here for therapeutic nihilism. We can do a lot. And in fact, I would imagine that cerebral small vessel disease is a lot like Alzheimer's disease. Much of it is silent. And if we wait too long for symptoms to emerge, it might turn out to be too late. So I think that we should try to detect early disease and intervene with the kind of lifestyle changes that Joanna mentioned, and also a sort of heightened control of vascular risk factors in order to prevent clinical manifestations. Because I think by the time you have gait difficulties and incontinence and dementia, it is really too late.
Could I just add to that? I think that's absolutely right. There's a lot we can already do. I kind of increasingly think that people who are prone to develop small vessel disease are in some way more sensitive to the effects of things like hypertension, because, I mean, we'll all have seen people who come to clinics and they have badly controlled blood pressure, but their brains don't look like that. It's almost like there's a resilience and then there's a susceptibility. So in somebody who does have white matter disease, subcortical small vessel disease at a younger age than expected or worse than expected, and they might have only relatively modestly elevated blood pressure, but what that might be saying is that actually they're quite sensitive to blood pressure, and we really need to make a huge effort to make sure that their blood pressure is well controlled, and that, you know, they're not smoking, and that, you know, their lipids are okay and things like that. And if they're diabetic, that their diabetes is well controlled, because maybe they're more sensitive.
And the second question for Professor Chen in this context is that if anxiety or mood disorders or insomnia in some way can contribute to the risk of small vessel disease.
I think the direction is the other way around. I don't think that poor sleep and anxiety cause cerebral small vessel disease, but they're part of the clinical syndrome. Very often people with cerebral small vessel disease have mood disorders and have disturbed sleep. And that could lead to more downstream problems.
Yes, sure.
Thank you.
Thank you. And there are questions for to Simone. The first one is how do we clinically differentiate between transient focal neurological episode and the Jacksonian march pattern or seizure?
It's a very good question. I think it's not always possibly clinically. I think neuroimaging helps us because with DFNE, we would expect to see an acute or at least subacute convex CSAH. Also, of course, with a new onset of a focal epileptic seizures, we would always, of course, also look for new focal lesions. So I think the MRI findings will usually give us a very clear answer. Clinically, I think these are the two that are probably the hardest to differentiate because both can kind of have these spreading changes. both can have both negative and positive symptoms. Often I would say the focal seizure is even shorter. But I think there's not a single finding that would help us to clinically differentiate this for sure. I think with TIA it's a lot easier. But mostly I think I would look at imaging and would see if there are convexity subburden hemorrhage. Is there on the other side the cause for the focal epilepsy, for example, a tumor or something?
Yeah, sure. And maybe they are more stereotyped, I don't know, in the case of transient focal neurological episode. And then the second question for you I selected is if no risk factor are present in the workup of white matter hyperintensities, what investigation should be performed, or genetics or cardiac or?
I mean, I guess it very much depends on the setting of what kind of patient we're talking about. Is this an asymptomatic patient? Is that a symptomatic patient in any form, like with an acute lacunar stroke? How old is the patient? Is kind of the extensity of the white matter hyperintensities, does it make sense with all the information that we have? But obviously, if this is a 20 or a 30-year-old patient that has beginning or early confluent white matter hyperintensities without an extensive risk factor profile, then of course I would, for example, look for genetics.
Thank you very much. And lastly, for Joanna, we have the first question is, what is your opinion for a single antiaggregant or DOAC use in lacunar stroke with atrial fibrillation? And another asked about the possible combination of antiplatelet plus anticoagulation. What do you think about?
Okay, we looked at this quite hard in the guideline on lacunar ischemic stroke, and the conclusion was that patients who have lacunar ischemic stroke, clinical stroke presentation, who are in atrial fibrillation should be managed according to the atrial fibrillation guidelines, which currently recommend DOAC. Although they do also raise a question about the effectiveness in the presence of small vessel disease. And since small vessel disease can be a risk factor for hemorrhage, there's just a question about being slightly more cautious. But in general, patients who either have covert small vessel disease or a lacunar stroke presentation of small vessel disease and they have atrial fibrillation, then they should be managed according to the atrial fibrillation guidelines.
Thank you very much. And the last question is, any other imaging modalities that can be promising, for instance, as biomarker of cerebral small vessel disease for progression, for instance, perfusion or diffusion, tensor imaging? What do you think about?
So I think CT scanning is actually quite a useful technology for small vessel disease. It may not show the microbleeds and the perivascular spaces in the same way that MRI does, but it's pretty good for identifying white matter hyperintensities and lacunes and also brain atrophy, which may be an associated feature. So I don't think we should overlook that. So far, we don't have particularly good ways of assessing CT for subtle degrees of progression, although I think those are in the pipeline with computational methods. As far as other MRI methods go, most of those are currently still research applications. There's evidence from diffusion imaging, which you can process in several different ways that will give indications of worsening white matter, normal appearing white matter health, as well as health in the affected tissue by white matter hyperintensities. Resting perfusion is a relatively insensitive measure of the blood vessel function in the brain. Cerebrovascular reactivity is a more sensitive measure, but it's quite specialist. It's not the sort of thing that you'd be doing in a usual, in a clinical setting. It would be the sort of thing you might want to implement in a research setting. There are associations also between things like retinal vascular changes, both fundus imaging and then OCT and OCTA. But largely those are associations. They're a sort of indirect way of looking at the brain. We probably could make more use of those in opticians where they see abnormal vessels, and maybe that should be more of a hint to go and look at the brain health as well. So yes, there are things, but a lot of them are either very research focused or not quite at the level of being easy to implement in clinical practice.
Yes, true. And I don't know, Laura, if we have more time for other questions, or maybe we finished our time.
I feel bad because there's so many unanswered questions. Perhaps we can do a follow-up webinar, or if our speakers are kind enough, we can do some questions in writing as a follow-up. I think we've reached the full hour. We went a little bit ahead of that. So if you all agree, I would just like to share the links where our audience can find our resources on the World Stroke Academy site, of course, but also on X and LinkedIn. The recording of today's webinar will be shared with all participants. You will receive a link automatically in your email address, and a link will pop up now for the evaluation survey. You can post more questions there, any comments, feedback, and as I said, perhaps a follow-up webinar will be needed, given all the questions we received. Thank you very much on behalf of the World Stroke Academy to our speakers and our chairs, and we'll see you in our next one. Thank you, everyone.
Bye-bye.
Bye.
Thank you very much.